Okay, for this sort of informal lecture, Kristy, Aristy, and myself are going to talk about different types of treatment settings that licensed addiction counselors can work in. We'll take a look at everything from publicly funded, federal and state prisons to completely, private, for-profit, cash-only kind of programs. And there's a variety of different settings in which people work. And as we prepared for the lecture, Kristy, you said a relatively small percentage of people wind up working in state-funded outpatient clinics, is it?
Yeah, usually state-funded or private practice fund or privately owned placements. Yes. Mm-hmm.
Mm-hmm. Yeah. So you have funding streams start out in the federal government. They come through in the forms of Medicare or Medicaid insurance that will be
Mm-hmm.
taken by some clinics. All of your publicly licensed, public funded clinics take that. And so the majority of substance use disorder treatment services are offered in an outpatient setting. They're offered in a variety of different levels of treatment, Kristy. We go from
Inpatient residential, right,
mhm,
which is probably the highest level of care
mhm,
in New York State. And then you have what we call 820 programs. The 820 programs can be inpatient or outpatient programming where you can get behavioral health, you can get any type of primary care, as well as substance use treatment combined together.
okay.
Then you have like inpatient rehab. Now, normally it's anywhere from 8 days to 15 days. It's really rare that, people stay in clinics for up to 21 to 28 days anymore, especially in New
Mhm,
York State. It's really,
mhm,
really rare. A person would have to seek a waiver through their insurance
mhm,
in order for them to stay in a rehab a little bit longer.
mhm,
Then there's
mhm,
inpatient detoxification services. Now, that can be anywhere from 1 day to 8 days. It
mhm,
used to be longer. However, what they're finding is that people don't need inpatient stay through a detox for long periods of time.
mhm,
And
mhm.
then they have the outpatient programs here in New York State, right? Medicated assisted treatment that handles all types of substance use disorders. Then
Okay.
you have medicated assisted treatment that's very specific to opiate use disorder.
So that would be
Um,
the methadone treatment.
it can be methadone, but it can also be Suboxone and it can
Mhm.
also be Vivitrol,
Right.
right?
Mhm.
So there's a huge, plethora. There's a real large plethora of treatment options now for people with opiate use disorder. Those are just the main three in New York State.
And when we look at the funding for those, it's paid for. The clinic is operating on some public source of funding. What kind of funding goes into those clinics to pay for, to keep the lights on, the bricks and mortar in place, and the counselors at their desk? Where's that
Uh,
money come
mhm.
from in New York State for these treatment services?
In New York State, it's really, really specific. What happens in New York State is if you're a state program, right? If you are what they call an ATC, it's a state-funded program. It's a program that is built and designed by OASIS, right? Which is the Office of Alcohol and Substance Abuse Services,
Okay.
which is our regulatory components here. If that is a state-run facility, they have what they call deficit funding. Deficit funding pays for people who are undocumented.
Okay.
They pay for people who just don't have an insurance but really need services right away. So
Hmm.
the
Hmm.
state provides additional funds
Sure. And
to
just to
those.
just to highlight one point you made, not to interrupt, but to highlight one
Sure.
point you made. So the state owns and operates the facility. They own the building. You know
Yes.
what I mean? That's where the money's coming for that. And then these are state paid positions the counselors are in.
Absolutely. You actually have to take civil exams to work in these
Okay.
particular types of facilities.
Which is why the licensing that we're helping the students, move in the direction of some students with these courses is,
Mhm.
includes all of the public health stuff. We have to test everybody for any,
Tuberculosis.
STDs or TB or any
Hmm.
communicable, there's a lot of that goes into that because it really is a state-funded public health program specializing in addictions, but really you have to cover everything. So the evals and the assessment instruments that that the students are going through, they have very specific sections on, medical history, et cetera. So we don't, as although you can be an addiction specialist, you have to really do the complete biopsychosocial exam. You got to look at the biology, the psychology, the psychiatric, as well as the social piece.
Absolutely, because I mean, how else will you write a comprehensive treatment plan and provide
Sure.
recommendation for referral?
And what's the role of insurance in health insurance in paying for addiction treatment in, say, one of these publicly funded clinics?
Okay, so if a person has Medicaid or Medicare,
Hmm.
or Medicaid, Medicare together,
Right?
or just
Yeah.
Medicare,
Yeah.
because there are so many different versions.
Yes, there are.
The state makes sure that they get paid based on what we call ambulatory patient guidelines, or APG
Okay.
rates.
Okay, so there's
So,
rates that are set, and those come through the public insurances, Medicare, Medicaid. I'm sorry to interrupt, but what if I walk through the door with my Empire Blue Cross and Shield plan
oh,
from
even
the
better. Thank
university?
you.
You guys
Thank
are gonna
you.
love that, right?
Oh boy, here's the deal. Every insurance company has their own rates of payment. There is
Mm.
no set rate of payment with an HMO,
Oh.
right?
Hmm.
Uh-huh. So,
So it's
mhm,
mandatory because we see in the second week of this module, it's mandatory that the insurance company provides coverage for mental health and
mhm,
substance use disorders. That
mhm.
bridge has been crossed. But what they pay could go anywhere from
It
less than
varies.
Medicaid to top dollar, I guess, huh?
Well, here's the deal. Most of the time, the insurance companies are going to pay less than the Medicaid, Medicare rate. They're
Interesting.
not going to pay, right?
Hmm.
They're not going to pay at the Medicaid, Medicare rate.
Okay, okay. I can tell you that's a New York thing, or it may be a locale thing. In rural
Mhm.
states, your private insurances are the best rate. Your Medicare, Medicaid, because it's administered state to state, and the reimbursement rate for Medicaid anyway is set. We have a rate setting commission, so it can vary a lot. Let me steer the discussion into the ultimate publicly funded addiction treatment service takes place in, drumroll please, Department of
Uh-huh.
Corrections in your state prison or, state correctional facilities, right?
Absolutely, the DOC.
Good old Department
So
of
what?
Corrections.
Yeah, yeah. In New York State, they're a great bunch. But here's the deal: in the Department of Corrections, what happens is when a person is released, the person is automatically mandated to go to treatment, whether they sold drugs or they use drugs.
Okay. Anyone who's leaving the New York State
Facility.
correctional facility is going to go to some kind of treatment. It's just part of
If
parole or probation. Hmm.
if they had a record of any sub of drugs on their record, then yes, it would. Yes, I wish I was kidding.
And oh, really?
Uh,
Who's in the correctional system that doesn't have some sort of record of alcohol or drug abuse? And they say, I'm sorry, all you partner, family member assault stuff, all your, domestic violence, yeah, it's, I mean, and then the crimes themselves of, possession of an illegal substance, it's driving under the influence. I mean, it goes on and on.
oh
Um,
yeah.
so yeah, and then the funding is going to vary from, we will be, we're teaching to New York, but we're also thinking in other states. The
Hmm.
funding that goes into treatment is also going to vary state by state, and I think New York does
Yes.
a pretty good job because they're fairly progressive with regards to understanding that you can't punish an addict into recovery. You're going to need to provide some sort of treatment in order to achieve lifestyle change. And that can happen in a correctional facility. Of course, people need to generalize those skills out into the community. Um, Speaking of my own state, now I'm in Montana. Uh, well, Montana may sound like a backwater to some folks, and we're a relatively, conservative state. Our Department of Corrections has 6 freestanding pre-release centers dispersed over a huge geographic area, several hundred miles between each, because we're such a large state. But each pre-release center uh, is designed to have people step down from incarceration into a lower level of security and integrate into the community. And in those pre-release centers, they have addiction counselors. And, if those positions are short, then they send them out into our publicly funded mental health substance abuse treatment centers. Because everybody, when they leave corrections, gets an insurance card and kind of goes that way. So there's different settings. There's the incarceration in prison. There's residential state funded. I have reports attached to this module from private, nonprofit agencies that have long-term contracts with the state to run 9-month residential treatment programs, after which people go to the pre-release centers that we have here. So there's that continuum of care from incarcerated, residential treatment, pre-release, supervised probation. They're out. The students have all read the continuum of care in a correctional system thing. So and at every step of the way, there's employment for addiction counselors.
Yeah, New York State used to have fully funded programs like that, but we no longer have those, a large portion of those programs. We still have alternative to incarceration programs.
Mm-hmm.
We still have, some halfway houses this is the colloquial language that we use.
Right.
But really what they're trying to do is they are doing what we call preventative services, right? They're putting a lot of money in preventative services right now. Right. So this means that before a person actually gets locked up or processed in a jail or prison, or goes through the main processing centers in one of the boroughs or one of the counties, the district attorney's office contracts with either treatment programs, peer programs, harm reduction programs. And
Mm-hmm.
what they do is they get certified recovery peer advocates or CASACs to go to the precinct to talk to the person who would have potentially been arrested, or who would have had some potential in having a death appearance ticket for their substance use, and they get treatment right when they're getting processed into the system, or right when they're getting a desk appearance ticket. And what they do is they're released on an RR, and or they're immediately transported to a program immediately. So that's becoming widespread in the boroughs here in New York State, because what they want to minimize the idea of incarceration for people that are using substances.
How's New York doing with the treatment court system? I included an article I wrote on the drug court and treatment court system in a rural state. We try to unify the data collection system. So the students will have some exposure to that in I think, the second week of this module. How's New York doing with you're talking about intervening at the earliest stage. Somebody's arrested and right away, it sounds like the court system's trying to get them involved in treatment, you said?
No, the district attorney's office.
The attorney's office. Okay. So they're making and enforcing a referral for outpatient?
Yes.
Okay.
Outpatient, inpatient,
So
any one of the services.
Does that become part of a drug court system? No, it's something different.
Here's the deal. If the person has a long history of arrest with substances, has a long history of, not complying with treatment in New York State, what happens is that they're often arrested and they're processed, and they do go through the drug court. Okay. Depending on the type of judge that they have, the judge may say, okay, you've tried outpatient X amount of times. Now I'm mandating you to residential treatment.
Oh, I see. So even before they go into the full drug court team approach, there's some opportunities for diversion there. That's good to hear.
Absolutely.
Mm-hmm. Yeah, once they get into a drug court, it's a formalized program that includes a team approach, including a judge, prosecutor, defender, counselor, probation officer, evaluator. Am I leaving anyone out, Kristy?
And a substance use advocate.
And they all meet as a team every week with the offenders in court. All 60 of them land in the courtroom. The team is there, and they go through case by case. Everybody gets to stand up and tell the judge how they're doing, et cetera, et cetera. If anyone's struggling with their chemical dependency, they try to come up with some sort of a sanction, or if they're doing really well, they come up with a reinforcement. They give them a reward. So the drug court systems are very cool. I'd encourage the students to do some more reading along those lines. So I think what we've been talking about is, inpatient, outpatient, private, publicly funded, et cetera, et cetera. Oh, about private, I showed you a link to the Malibu. There's these,
Mhm.
if you're wealthy, or even if you're not, there are people who will mortgage their house and spend their pension and life savings trying to get someone in the family into recovery by putting them in the best treatment that money can buy. And you get into some really glitzy country club kind of residential rehab treatments. They're all up and down the southern coast of California. Every state has a few. I'm sure they're still running in New York.
Sure
Um,
are.
so there's that, and then you get a mix of what insurance is going to pay for it. Well, not not generally publicly funded insurance. Some private insurance will pay for some programs. It depends on accreditation, et cetera, et cetera. So a lot of different levels and types of treatment out there. We'll start wrapping up the lecture. One footnote, I spent a good part of my career in a private practice. I was self-employed. I took insurance companies, Blue Cross and Shield, et cetera, Cigna, Aetna, all of those had a contract with the U.S. Post Office that would pay me to see people. So, that's a kind of an independent practitioner. That's a little tough on addiction counselors. You want to be part of a group, as we'll see as
Mhm.
we get into this. You have co-occurring clients, you have personality disorders, you got criminal involvement. It's not the kind of thing you want to be doing all by yourself in an isolated office all week. Kristy's shaking your head. It's like, no, you
Nope.
don't. So you really want to have a close, kind of community, but you can be private practice, self-employed, substance abuse counselor, because we're social workers. We have the license that can bill different things. So
Right.
there's that
Mhm.
option as well. That's where some people wind up. Uh, and that's primarily with your clinical social work license that you can set up, reimbursement panels, et cetera. So we kind of covered it, Kristy. Anything else you want to talk on varieties of different kinds of treatment settings people can wind up in?
Yeah, just one that's really special and unique to New York State, which is the outpatient stabilization and withdrawal services.
Okay.
So it's really, really cool. It's really, really unique. So for people, what New York State noticed was that mothers, people who had families that they were taking care of, right? Parents that they were taking care of, weren't
Mm-hmm.
able to go to detoxification for more than 2 days because they
Mm,
didn't have anybody to take care of the people that were in their home. So
right.
what Oasis said was like, we have this large population we can't reach. And we also have this large population who has to continually use this revolving door effect
Mm-hmm.
because they're unable to stay or complete treatment. So it's very specifically detox treatment. So what they
Okay.
said was, this is what we need to do. If we can take a person out of their home for a couple of hours and monitor them while they're detoxing off of a substance,
Right.
and then they can go home and come back the next day to continue their detox.
Okay.
We think
Mm-hmm.
we're gonna have a higher prevalence of people completing treatment. And the numbers actually show, right? According to the Oasis, if you look on the Oasis website, they have all of
Sure.
their numbers available.
Mm-hmm.
There's definitely an increase, a significant increase showing that people are going to this outpatient stabilization and withdrawal service. They're
Okay.
able to take care of their families and they're able to complete treatment.
So you can compare that program to treatment as usual, and you'll have a superior outcome, which is
Mhm.
evidence, a basis in evidence that the program's effective, called an evidence-based program. We used to call that ambulatory detox or outpatient detox. What are you guys
Mhm.
calling it in New York City now?
We call it outpatient stabilization and withdrawal service.
Nice. It's great. As the students will learn more about withdrawal as we go along. I mean, it's certainly in the DSM. You can
Mhm.
pull that out. You can see it in the 11 criteria in the DSM. That outpatient, that withdrawal syndrome it's very tough. An individual gets very, very sick when they stop using some substances, and that's why they'll return to using them. So that's a nice service and a nice cap on the lecture too, Kristy, to talk about the different modalities of treatment, the different kinds of programs that people will find themselves in. Corrections, inpatient, outpatient, private, publicly funded, run by the city, et cetera. So I think that about covers it for now. Any last thoughts?
No, that's
Good
it.
to go. Ending the lecture. Okay, students have their the rest of their assignments in the Canvas board, and look forward to continuing to work with you.